Hey everyone, welcome to the Brain Body Reset Podcast. I'm your host, Spencer Zimmerman. Beyond the diagnosis and symptoms, there's a path to feeling better. Dive into the world of brain-body connection and learn how to optimize your health. In this week's episode, I'm joined by Dr. Scire, where we go at childhood developmental disorders from a twist. Everyone thinks about what can you do when they're little, but what happens when they get older and it never got treated? Is there anything that you can do to help improve their brains when they're in their 20s, 30s, or beyond? That's what we're discussing, and I hope you enjoy. Dr. Scire, great to have you here.
Great to be here. Thanks for the invite.
Yeah, you're welcome. So I'm excited to talk about childhood developmental disorders and really almost kind of leaving the childhood side behind and talking about, is that really the end of treatment and growth potential that they have, or is there more that can truly be done for their brain health? So excited to talk about this with you.
Absolutely.
So first, when we really look at these developmental disorders, I think if we mention developmental disorders, most people instantly just go to autism, right? What are some examples of developmental disorders that kids have, not only things that maybe people recognize, but other things that maybe are there, but people just, it's not talked about as much. So people don't even understand it truly exists.
Yeah, well, obviously we're coming off the heels of autism in April, right? The autism month, and got so much press and everything that's going on, even with the MAHA movement in this country and everything. But honestly, autism is only not even 3% of the population of school-age children. The number one childhood developmental disorder is actually learning disabilities and dyslexia. But because of the diagnostic or lack of good diagnostic workup on those children are often, identified even at the elementary school, maybe at the middle school level. And if they are, it's a very poor workup. Then we get into learning, get into ADHD, and ADHD probably being about maybe 10% of the population, maybe upwards to 15. And then, like I said, autism and the spectrum of autism. And then we get into the differentiation of what we've described in the past as high functioning autism versus moderate autism to profound autism being the non-speaking. And then you have the comorbidities that exist in there. You have the children that have tics or Tourette-like symptoms. Then you can also see children being diagnosed with obsessive and compulsive disorders, social anxiety. For many years, they used a non-pragmatic learning disability, non-verbal learning disability. At one point, we were obviously using Asperger's as a diagnosis. So you have this wide consortium, but and then you have mood disorders. You actually have true mood disorders and even behavioral disorders like oppositional defiance. And so, coming from my background and where I've lived for the last 20 years of my career, we're looking at this through the lens of Dr. Malil's work and hemispheric patterns of left brain. I think for many of the students that I'm seeing these days is I'm working with a population of kids probably from, let's say, 17 to 30 years old. And when they come in my office now, they truly have bona fide neuropsychiatric disorders, like those profound mood disorders or insomnia or anxiety disorders. Some of them have been treated medically with medication. Some of them have been self-treated themselves with marijuana and even just recreational medications and stuff. But it's really predicated on that brain imbalance that started early on and was probably never identified correctly and obviously never treated correctly.
Yeah, and I want to go to learning disabilities really quick because you mentioned that, is over 20%. How significant is this on these kids' lives as they become teenagers and then adults? Because we get people all the time who we both see who are like, oh yeah, I have dyslexia, I mix up some stuff. But it almost sounds like when people say dyslexia, it just gets really minimized as if it's like, oh, it's there, but it doesn't really matter.
Now, I think that's a great point. And so, first of all, dyslexia is not just the actual switching of letters or even numbers. Is actually what we call phonomic awareness, the inability to actually identify your phonemes. For example, the differentiation between sh and ch. I mean, my own story was that I was actually a child with a learning disability and really probably an underlying central auditory processing disorder. So that's something that's there. We can see visual processing disorders. And so I think that, they do get minimized to the extent of, it's just this thing where they switch numbers or they maybe write their letters backwards or something. But, for us and how we would diagnostically look at it, it's a much greater problem. And it really stems from this delay in their visual system, especially the visual system primarily to the left side of the brain, combining that with the auditory pathways of the left side of the brain. And then a lot of instances, we can actually see quite a bit of problems in muscle tone as well. I mean, we see that in the autism population and the ADHD population. But what's fascinating about a lot of these learning disability cases, and I've worked with loads of them over my career, and I actually have several of them currently in my office. And, they have some very almost like gifted motor skills in the sense that they have an interest in playing sports. But when we actually look at some of their midline ability of their spine and their cerebellum, they have quite a bit of midline disruptions. And oftentimes they actually have tremendous underlying vestibular problems that may contribute to the oculomotor deficiencies that we may see. These obviously problem of eye muscles in terms of gaze and smooth movements of eyes or rapid eye movements that obviously in our functional neurology group that we're trained to look for. And then you also see a tremendous amount of retained primitive reflexes in this patient population.
Yeah. And I want to, because there's going to be people who this is the first time listening to this podcast and probably even their first time hearing the term functional neurology. Can you briefly explain, what the functional neurology concept is? Because it's definitely very different than traditional neurology when people hear the term neurology.
Yeah, it's a field that emerged practically basically almost 40 was the originator of it, and we're all descendants of that, and we're multiple layers of descendants from practitioners from that. But the ideal aspect is that functional neurology, to look at the functional capacity of the nervous system, we're taught how to do a neurological exam, and I think even more extensively at a bedside level than probably even a primary neurologist would do. But we're actually looking at the function of the different parts of the nervous system. So we may look at, for example, talking about the inner ear and talking about the vestibular system, and we may put patients through a variety of different balance testing and head movement positions and look at the functionality of that particular area. So I think from a standpoint of how we go about it, we're going to be looking for the capacity of the nervous system and how it's functioning. We're going to also look, obviously, for frank neurological pathology. But most of the time when we're actually treating these patients, they actually have obviously just disturbances in different parts of their nervous system. And we know that from a developmental standpoint that the lower parts of the brain are feeding into the upper parts of the brain. And a lot of people that may have problems in cognition or problems in relationship to moods, or they may see, again, changes in their memory. They may actually have problems in the lower parts of their brain. So I think for us, we're always looking at this relationship of how does a pathway function? And we've just been trained at a very high level to go in and measure these at different levels of what we've always referred to as these longitudinal levels of the nervous system. So we take this step from looking at the muscles of the extremities, and then working forward and working backwards towards the spine, and then upwards into our brainstem, and so on. So I think that's how we go about doing it.
Yeah, and whenever we look at developmental neurology, because once again, we're going to be talking a lot about neurology. What, are some of the things that we should be considering? Because I hear you talking about vestibular function, talking about oculomotor function, because most of these kids who get diagnosed with learning disabilities, right? Dyslexia, visual processing, auditory processing disorders, just overall sensory processing disorder, or autism, any of those, they're usually not getting neurological evals. Usually it's like maybe they see a pediatric neurologist, but normally they get shifted to more of psychiatry and then to OT and PT for, I'm almost, I'm not even going to say rehabilitative treatment, more of here's how you deal with what you have treatment.
Mm-hmm.
Right. So,
Yeah.
How does that tie in when we look at developmental neurology in the vestibular and oculomotor systems?
Well, the concept of developmental neurology is the idea that there's a developmental blueprint. There is a developmental blueprint of the central nervous system. It starts obviously in the womb, and there's certain neurological circuitry that's starting to emerge within several early weeks of gestation, okay, and through of gestation. And one of those primary functions is what we look at in terms of these primitive reflexes. So primitive reflexes are these automatic reflexes that that respond to environmental stimuli in the womb as well as soon as the child is born, and they're automatic, they're stereotypical, and that all humans have them. And we go through these different steps through development of these primitive reflexes. The first 12 months of our life, when we're born, the upper regions of our brain are really not developed because as a human brain, we have to have a very small cranium for an infant to be able to be born. Okay, it's not like a horse or some other mammal that can be born and then all of a sudden walk. So we have human brains have to be tiny, and then as they engage with the new sensory input upon birth, the parts of the brain that are more metabolically active at the time are living in our brainstem, and they're really governed by these primitive reflexes. And we go through these very specific steps of how these primitive reflexes, when they appear, when they should turn off, and then allow for other reflexes to mature. And so there's a trajectory of development. We have very odd movements, reflexive eye movements early on at birth, and then we develop more, what we call volunteer eye movements that we actually have complete control of. And so when we talk about a developmental relationship, there's a developmental relationship of how the brain is going through its early development, and this actually leads into the development of what we call brain laterality. Okay, that there is our two hemispheres. There is actually a blueprint on how they're developing. And so from birth to the first 3 years of life, the primary hemisphere that is developing is the right hemisphere. And then around about 2.5 years old, the left hemisphere becomes more developed, turning on and developing. And that's where we begin to see much more language development from a child. And what happens is that there's this developmental sequence of this right to left development that happens all into late stages of teenage years and into early 20s. And now we may think that this development goes on way into our mid 20s. And so there's this neurological group. And so from a developmental perspective, what we're doing and what Robert Malil and I are teaching practitioners to do is to be able to go in and examine for where the developmental blueprint goes sideways and where we have problems in that. And the easiest way to do that initially, and especially in an early child or even in an adult is look for retained primitive reflexes, because they, again, should not be there after about 12, 15 months of life. And if they're retained, they're literally actually slowing down that maturation development of the hemispheres.
If you're finding this information valuable, please share this podcast with others and give us a 5-star review, as that is the only way this podcast grows. Please continue listening and keep enjoying. Yeah. And so, So with, evaluating primitive reflexes, we've talked about balance, vestibular system. Why, for those that are listening, why should they be considering like, hey, maybe this is something I should have my 16-year-old kid, we should be talking about their development? Or why should a 25-year-old who maybe had a prior diagnosis, of dyslexia or visual processing, why is it important that they communicate with their provider or find the right provider to really talk about their developmental history, and they don't focus just on what's going on at that moment in time? Because that's what a lot of people tend to do, is say, here's what I've got, right? Let's focus on what's most recent in our history versus looking at the spectrum.
Yeah, well, I mean, it really starts from the idea that motor function drives cognition. Okay, and we can look at the work that Jeremy Zimmerman from I think he's at it's not MIT. It might be MIT, but he's been one of the people that for 30 plus years has been looking at the role of the cerebellum, the back portion of our brain that we used to think was the main function for muscle tone and balance and posture and gait. But as brain imaging emerged in the late 80s, we realized that the cerebellum actually had all these contributions to different parts of the brain. When you look at movement as one of the primary functions of the early development of the child, I mean, what comes first? Does movement or speaking come first? So we know that movement and complex movement, and especially bipedalism, emerges first before the motor circuit. When the motor circuits are not functioning ideally, we're not going to see the normal maturation of these more advanced cognitive functions. And that may then show up in how the two hemispheres are actually developing from a standpoint of their asymmetry, okay? And we may then see where we have these cognitive deficits from right to left side of the brain, or we may have in our social development. And so that's the real big thing, is that, what we're looking, and what we're diagnosing is we're diagnosing the deficits, and we're naming it, but we're not actually saying, okay, what's the primary reason for why this happened? And it actually really happened because along the way there has been all these aberrant motor milestones or sensory motor milestones that actually have been missed, and now that's led to the immaturity in these more advanced cognitive skills and executive functions and so on.
Yep. Yeah, exactly. It's just like if you have a team and you're trying to train them to do stuff, you always have the foundations that everything's built upon. And if the foundation's not done right, you then start getting some issues. You start getting mistakes and stuff that really shouldn't be occurring. And same thing with this, you go back and say, what's the foundational stuff that should have been addressed? And you've got to take care of it for the other things to really develop and grow in the way you want them to.
Yeah, and it's very essential, and I think that's what's been missed for. I mean, again, I've been doing this work for 20 years, and I think I've seen the gamut of how these kids are worked up diagnostically in the traditional model, like you said, even from the occupational therapy model or physical therapy or speech language pathology. Mostly looking at maybe one area, whether it's just child doesn't speak properly, we're going to work on some training of some muscles of speech and everything, but not realizing the contributions that other parts of the brain may play a role in that functionality. And again, teaching this for almost 15 years now, and knowing what's the education of those disciplines. It's always shocking when you get speech pathologists or OTs or even PTs that come in and go, wow, like we never were taught to look at this developmentally. We were just taught to look at this in a very linear way, and maybe look for some muscle imbalances and stuff. Or, again, they, activity of daily lives that they may not be able to do, and we may work towards that. But not to go and say, okay, what is the blueprint of the brain, and how do we, work by repairing this blueprint?
Yep. And it's definitely a different framework than most people are used to. Because like you were saying, right, people are used to going, oh, I've got cognitive issues, I've got speech issues, I'm going to see a speech language pathologist. You definitely see a lot more kids and teens and even adults with neurodevelopmental disorders than I do. But even with, those I treat and the amount of concussions, they're always like, wait, what? You mean doing like vestibular and oculomotor based therapies is going to improve my cognition and my ability to find words and improve my memory? Like, I thought I needed speech for this. And that leads, unfortunately, to a lot of people not getting the proper care because it's still something conceptually. It's not really talked about in the world of really brain health in general, whether it's neurodevelopmental, acquired injuries. It's just like, oh, well, you've got this, you go for that. It's like, well, it's not actually the best way of going about it.
No, I think you're right. And I think they're phased to this too, and I know we live in this world together as well, and the crossover of functional medicine. And I think that's even a calamity itself, because now everybody gets into, it's mold, or it's histamine intolerance. And it's all these things that are driving these problems in the brain, and they're still not understanding functional connectivity. They don't understand the fact that there is these aberrancies in the trajectory of a developmental blueprint that changes the way these hemispheres are communicating to one another, which is then going to change downstream relationships of how the individual hemispheres are dictating the function of the immune system, or the cardiovascular system, or the endocrine system. And so everybody that's looking at those systems from a functional medicine piece is really missing functional neurology, and especially developmental neurology. And I'll see families that have gone to really talented functional medicine practitioners over the years, but they come in my office and they've run thousands of dollars of labs, and they're on 20, 30, 40 supplements, and get a whole spreadsheet of supplements, and is your child any better? And I'm like, no, because again, you're not addressing the primary source, which really for the vast majority of these kids is this imbalance in their two hemispheres, and that one side of the brain is been thrown into a more growth development, and the other side of the brain is lagging behind. And one of the potentials for that is, are we seeing where we're getting generationally gifted children, especially in the autism population and the ADHD population, where they're traits that are being passed down from parents to grandparents. And it's a common theme I see in my office, where we get a child with an autism diagnosis or an ADHD diagnosis, and you can look no further to probably the father or even the grandfather and see these very dominant left hemispheric traits. And Simon Baron-Cohen and others about this for almost 20 years now, called like the geek syndrome. Okay, so I don't think it's something that we're talking out of turn. I think it is truly there, that you can get these in traits. And so even though people are like going, oh, there's all these environmental stuff going on, and all these things, and problems in our foods, and the whole vaccine discussion and everything, but the reality of it is that you can actually look back and see these dominant hemispheric traits that are appearing in a lot of families that could be influencing the way these hemispheres are beginning to develop, or changing the way that pattern happens. And then that's going to have a consequence on those other systems. And so you have to go back to the central system, being the central nervous system, to have a better long-term effect on those other systems. And if not, you're even in the functional medicine world, you're just symptom chasing then.
Correct. And there's a lot of symptom chasing in that arena. And whenever I talk to patients, like, well, what's different? I'm like, well, I look at both brain health and body health. It's not one or the other, because we've been knowing what we do, right? There are those in the neurology space, functional neurology, who only look at the brain.
Yeah.
But they ignore outside influences. And then there's, functional medicine that often ignores the influence of the brain, and they try to treat everything neurologically through any mechanism other than the brain. Now, that doesn't mean it's not going to work for some individuals. And this kind of brings us to what we're going to talk about next. We both have a love of immunology and the immune system, right? Because we know it's not all that neurology lives on its own. We know that there's an influence of the immune system as well. So, kind of let's walk through that. How does the immune system play a role in neurodevelopmental disorders that not only impact kids initially, but how it can keep impacting them as they grow into teenagers, young adults, and they enter adulthood?
Yeah, so it's a great conversation here, and it's you might get a little intense for our listeners, but one, it comes down to starting out with the two elements of the immune system: the innate immune system, and the adaptive immune system. And we know obviously the innate immune system is going to respond very rapidly to different pathogens and get stimulated by these pathogens and try to recognize them and mount a rapid response. And if they can't mount a rapid response, they're going to take a piece of that pathogen and then present it to our adaptive immune system and engage our T and our B cells. But when we're looking at these children with these developmental disorders, one of the things we're seeing right now is that if a mother is in an inflammatory state in terms of maybe they're having, maybe they're obese, during the pregnancy, or they develop an underlying metabolic disorder, like maybe they have diabetes during their pregnancy, or they have a history of autoimmune disorders themselves, they may actually change the way the immune system is functioning in the development during the gestational periods, where they actually start pushing the adaptive immune system too aggressively in early development. And so it drives this brain to get into a more in what we call a really pro-inflammatory state. So we start activating very specific branches of our T cell positions, and one of them being what we call our Th17 system. And so there's this term called maternal immune activation, called MIA. So MIA is where this very dominant inflammatory response, and does this inflammatory response then alter the contributions of our immune cells during normal neuronal development that, probably in only the last 30 years, neuroscience and neuroimmunology specifically figured out that we have obviously these immune cells in our brain called our astrocytes and others play roles in actually kind of like the scaffolding of the brain and the building of our individual neurons and the maintenance of those neurons, and as well as the connections of those neurons. And so do we get maybe an excessive inflammatory response early on to we may get an altered ability of how we build those early connections in the brain, as well as postnatally. Then is the child into more of an inflammatory state themselves, and does the immune system begin to create more of a memory to that inflammatory state? So now when they are with particular responses to their environment, whether it's a food that might create an inflammatory response, maybe a chemical aspect, or even when the immune system turns on to kill a pathogen, whether it's bacteria or virus or fungus, that we may get a very aggressive immune response. And so what does that do? Well, that might actually prime these microglia more aggressively, and now we get this thing called neuroinflammation, and we get this inflammatory storm at the brain. And at that level, what does it simply do? It really basically slows down the connection speed of the brain. So yeah, there's definitely this immunological relationship, and then taking it one step further and saying that each hemisphere has a role in the immune response. And for the most part, the laterality research has shown that the left brain tends to have more of an inflammatory response, telling the immune system to turn on and go, and that the right brain, through more inflammatory mechanism, primarily through vagus and the cortex, through the autonomic network has an anti-inflammatory response. So what it should tell the immune system to do is to come to a level of resolution. But what's happening is that if the brain is immature, that the child, when the immune system turns on and does its job, it may not turn down. So now we get this constant promotion of the inflammatory response that then causes gene expression, and we may end up developing autoimmune expression to our body.
Yep. And it's really important for everyone to know, whenever we talk about like left hemisphere being more inflammatory, it doesn't mean if, oh, well, I'm a little bit more left brain, you're going to be in massive inflammation, because really these should be shifting back and forth. So,
yeah.
We don't always need to consider inflammation as bad. It's anything that's sustained is what's bad. So even someone that's stuck in an anti-inflammatory state, which, as we know, it's not even necessarily truly anti-inflammatory, it's just which side of the immune system is being biased. Any shift from really a balanced state, I kind of tell people it's like a seesaw. You want to go back and forth depending on what's happening. But it's when it gets permanently in a place or persistently stays there, that's where we get issues. And the more I learn, I've really just kind of broken everything down. I'm like, most things I see in my office are neuro and immune issues. Like, I'm like, under the immune system, I'm like, sure, yes, there's gut, there's all of that, right? That impacts immunology. But I'm like, most everything I see now is neuroimmunology. And going into that arena, I know we've talked about it briefly, but I want to dive in a bit more now. It's mood disorders, as a truly neurodevelopmental and a neuroimmunology issue versus the way most people are used to them being treated. Most are just used to being treated with, here's your Lexapro, here's your Prozac, here's your Cymbalta, right? Wellbutrin, oh, you got a lot of anxiety, here's your Xanax, and kind of that whole side. And we routinely see, the research is pretty clear on this too, that the meds, they leave a lot to be desired. And the research really isn't even showing that it's necessarily truly a psychiatric issue. It's more neuroimmune. So let's talk about that for a little bit.
Yeah, I think you bring up a great point that, when you're looking at those type of medications, you're talking about changing receptor site sensitivity, to that, or you're trying to turn off with an SSRI, and so. But we know, even going back to probably the mid '90s, that there's been this relationship of neuroinflammatory mechanisms that happen. That let's say we have a stress response, we have an external stress response. Do we start stimulating the production of hormones coming from our pituitary gland that then signal to our brain, to our body, to our macrophages and other cells to pump out inflammatory cytokines, these inflammatory signals, okay? And then make that, and then that's then going to loop up, and then it do the same in the brain, and then what does it do? It impacts, it downregulates transmitters, downregulates our ability to make our brain-derived neurotropic factors that actually maintain plasticity. Okay, so we get these looping effects. We can also coact cells, and so we know the brain is filled with mast cells. So now do we get this dumping of other pro-inflammatory compounds, aminoleukotrienes, prostaglandins, that create this neuroinflammatory storm. And then, we know anatomically in the brain that there's different receptor sites that are more found in certain areas of the brain. And so now do we get a docking of these pro-inflammatory cytokines that dock onto the cells and then cause a gene expression inside the cell? It creates an inflammatory event. And so that definitely happens. And I've seen it clinically for years and years and years. And it can be a variety of different things. It could be stress chemistry. It can be, again, reactions to certain, food proteins, and like the glutens of the world and the dairy of the world, and even some of the cross-reactive foods that they may have a similar protein sequence, and they may, you may develop a reactivity to dairy or gluten, but then you eat corn, and now you're cross-reacting. because of the similar protein reactions, or even, work that the Teeth Karazian and the Ari Vajani have done, and looking at even like, stuff like spinach, okay, and looking at certain types of reactivity there. So there's so much of that's happening. And I think that's superimposed on the brain asymmetry. I think that, the brain asymmetry is definitely there. And the more that we're beginning to understand about the constitution of the right hemisphere's relationship to sickness and in the right hand side of the brain, and especially the insular cortex's role in trying to control that inflammatory response, and say, okay, hey, like you said, we need inflammatory responses. Okay, we need our T cells and the branches of our T cells to go and fight intracellularly and fight, pathogens that get inside the cells, like viruses, and they're going to create an inflammatory response. But how good are we at turning that down? We need the part of our T cell system that's going to fight extracellularly and fight bacteria that's, in a tissue or in our blood. Okay. But again, how good is our immune system at turning it down? And if we don't turn it down, then are we're getting tissue destruction? Are we what we're calling DAMPs, damage associated molecular patterns? And now is that creating another problem for us, because now our immune system is tagging that tissue and saying, okay, hey, I want to now, break down that tissue further. And that's what can obviously lead into greater, autoimmune expression.
Yeah. Yeah. And I know that was a lot for a lot of people. I just want you to know this is very nuanced, right? We're not here to be like, oh, well, there was some research that said fish oils could help with autism, or fish oils, right? I know there's supplement companies that are like, look, here's the fish oil blend we got for ADHD. This is what's going to do it. Realistically, it's not that simple. I always tell people to avoid places that try to reduce everything down to, here's the one thing you do and it takes care of it. But as you went through, right, there's a lot of different things, from foods that people are eating to chronic infections to gut health to stress chemistry and everything else. And these all interact, but also at the same time, and this where we're going to go next is, we also don't necessarily try to address all of those at once, right? There may be times we do, but there's other times like, no, where's our greatest leverage points? Because I assume you're probably not practicing the same way now that you were when you first graduated from school and kind of started doing this about 20 years ago.
Yeah, absolutely. And I think that a couple of things, obviously we've been talking about the neuroimmunology and, kind of, when you and I probably got into this, there was only a beginning understanding of the T cells and the different branches of the T cells. And now we know that there's, just under T helper cell system, there's about 7 or 8 or even maybe potentially more literatures of what that, and they're doing different things. And so, like you said, the idea that just these example, you hear a lot of people, talking, you always, you log on to Instagram, everybody's talking about NAC, N-acetylcysteine. And you and I both know that you better measure a certain marker before you go, specifically this marker called TGF-beta, before we go and just start blankly giving NAC, because you actually could, if that TGF-beta is way elevated and you give somebody too much NAC, you can actually push them into a very aggressive inflammatory immune response. And so I think that's the big thing that I've tried to explain to patients, is that, we are trying to be really in about this idea of immunotherapy, very specific with how a certain compound is going to drive an immune response, and whether it's going to upregulate that immune response or downregulate that immune response. And so that's something that's dramatically changed, especially for me over the last 5 to 7 years in my practice. And then the other thing from a neurological perspective is that early in my career, when I started doing this work and started working with Dr. Malil, and we started developing this model to identify the brain imbalance and then treat the brain imbalance, a lot of it was based on the fact that we were trying to activate the brain and bring up the low side. Okay. And for instance, in children that had more like ADHD or autism or Asperger's, it would be the right side of the brain, and we would do all these different modalities simultaneously to activate that one side. But in some of these very gifted cases of, like, let's say high functioning Asperger's, or even some of these cases where there was a lot of obsessive compulsion type of manifestations, just bringing up the right side may not be enough to impose an inhibition to the strong side. So this was something that we knew, we recognized it fairly early, but we didn't have the technology at the time to do that. Now, fast forward over the last 4 or 5 years, we've now been able to utilize different technology, whether it's transcranial stimulation. I know you've looked at transmagnetic stimulation as well, utilizing the use of low-level laser, and even now maybe even developing some different neurofeedback protocols that, while we're actually trying to upregulate the weaker side, we're trying to slow down the overactivation or the overconnectivity in different areas of the brain, or what we refer to Brodmann areas of the brain, on the stronger side. So just like in immunology, where I think a lot of people in the functional medicine world just take this blanket statement and go, hey, immune support. Let's just throw everybody on these basic immune protocols. You and I both know that's not how it works. There's very discrete ways to assess the immune system now, or had through mainstream labs like LabCorp or Quest, but even some of the obviously specialized labs in functional medicine. And so the same thing goes with the brain, is that we have to now just say, well, maybe 10 years ago, we would have said, okay, hey, only stimulate the right brain and we can make a difference. And we made a difference in a lot of students at the time. But there was also students that we could have done a better job. Well, now we understand how we could have done a better job. And that's probably the two biggest things that have changed in my practice is understanding excitation and inhibition, and from a rehab standpoint, and then even from an immunological standpoint, is that, I'm trying to bring a somewhat, like you said, a balance to the system, but how do I, and I may at times have to slow down an overactive immune system before I'm trying to bring up a system.
Correct. Yeah. And I just want to make 2 points. One of the things you said was trying to do a better job. And I think that's super important, that when people are trying to find a provider, it's okay to have one that's evolving. And you're like, wow, you're doing things a little bit differently than you were 2 years ago. It's like, yeah, that's actually a good thing. In the world of immunology and neurology, if you're seeing someone who's still doing stuff they did 5-10 years ago, it doesn't mean they can't be doing parts of it. But if they're doing that as their entire thing and there's no evolution, it's, that's kind of a red flag. It's just like, you're clearly not staying up on any of the research. And then the other part is, with balancing things, right? We can either excite or we can inhibit. We can kind of do both. And it's even the same thing with the immune system, right? We can turn up one side, but we may also have to turn down. And that's also important, right? Because some of you have been told, oh, well, my immune system is overactivated. I know you probably run in this a lot too. And I'm just like, it's not that simple. It's which side of your immune system. Like, there's different layers. It's not so black and white now where we can just say something's overactive. It's like, well, I mean, is it overactive? Like you've got eczema, like you get sick all the time. Like which side's biased? Like we don't know.
Yeah, exactly. Like, you and I both know that, back to this T helper cell position, and years ago when we first probably got exposed to this, we got taught that there was a TH1 and there's a TH2. Well, we now know that TH2 has a nastier version called TH9. And so people can have a more TH9 expression of that, not maybe that mast cell component, but may now push them into more of a respiratory problem and a COPD type of problem and stuff. And so, how do we address that differently than we would address an asthma? So I think for us, I do agree with you that I think that the patients out there that are going to be listening to this, try to encounter providers that are constantly taking their continued ed hours. I think the general amount of hours that most of us have to maintain per year for our licenses, no more than 20. I mean, I know I've been taking, classes, upwards over 150 classes a year in continued ed for 20 years, not counting what I actually teach in continued ed hours and stuff. And so I think that, and then reading journals and reading articles and getting with colleagues that are in that same mental space of hey, I want to hang out with so-and-so and find out what they're into and everything like that. So I think that's important, is that I always tell patients that, you said that, is your practitioner evolving, or still holding on mostly to philosophy, more than anything, and not, actually looking at the emerging science that's out there. And we also know, we've been around this long enough to know that there's a big gap between, research and in clinical application. I think we're fortunate that we hang around with some, very bright instructors that are close that gap for the rank and file clinicians that want to get that education, but you got to want to go get it and learn it and stuff and then apply it. And so I think that's a big thing. And I think that's why it makes sometimes it makes it challenging for guys like us and gals like us that are on the frontiers, because we sound like the weirdos because we're actually so in front of everybody, And so, I mean, I look now and 20 years into this, and I turn on Instagram and I see all these people talking about primitive reflex and everything. And I'm like, where were you, 15 years ago when I'd go do a lecture at a small group for ADHD and maybe have 3 moms show up and we're like, what are these primitive reflexes about? So I'm glad, the evolution of it's happening. But I still think that there's a lot of practitioners that are somewhat, practicing in the dark ages.
Correct. Yeah. I mean, there's plenty of people who are staying behind, and because the fact is, it takes sacrifice, right? Me and you are on calls Tuesday night on our own free will, like
Yep.
we choose to, and we're on it more often than not because we're wanting to learn. Because the fact is, if we have to go and do everything on our own, it takes longer. And so it's like, people are like, they're like, who's your mentor? I'm like, for which aspect? Right.
Yeah, exactly.
There's not one person.
Yeah. And, again, you and I have been on those calls for years together. And even when we're on those calls, there's probably no more than 25 people on those calls.
Mm-hmm.
And then, I know who some of your mentors are, and who my mentors are. And, we go to their conferences, and maybe there's 40, 50 people in the room out of tens of thousands of practitioners that could be there. And for whatever reason, they're choosing not to be there. So I think that, for us, it's always been a challenge, but I think it's a fun challenge to be able to educate patients and educate people and say, listen, this is the frontier. And I think that, for me now in my year, entering year 20 of my practice, for the most part, I have just purely a referral practice. I don't have to spend an enormous amount of time marketing, because most people are just like, hey, that's the guy you want to go see, or someone like yourself. I mean, and so I think that's the beauty of trying to stay ahead of that. And we know that some of our mentors are getting up there in age, and we're trying to get as much out of them as we can before, they may decide to retire or whatever and do something different. And we're that old guard now that is expected to go and teach all this stuff and keep advancing the protocols and so on.
Yep. So, I mean, really, people just keep looking, and honestly, you don't really know till you experience it with providers, kind of how good they are, because there's a lot of terms that people are using now. Oh, I do functional medicine, or oh, I do I'm a neurology centered chiropractor, or whatever it is. There's a lot of things people are doing because it works marketing wise, but it doesn't really tell you how good they are, which unfortunately is adding to a lot of confusion. But where I want to go next is, let's just run through a couple pretend cases. We're not necessarily going to talk about how we do treatment, because for me, it's, that's nuances and people. Yes, I understand you want to know, oh, but what's the treatment? But I like the framework, right? What's the framework that's actually going to provide us with the information we need to actually make smart decisions versus rushing to something because it sounds good? Because a lot of people rush to things that sound good on social media and then it doesn't work. So let's pretend, right? We've got a 18-year-old female. She comes into the clinic. She has a history of visual processing disorder, and she's also been diagnosed with depression and anxiety and has previously been on meds for that. She may currently still be on them, but it's just not quite doing it. Kind of let's walk through a framework for that.
Yeah, well, number one, I mean, it starts with my intake forms, and I'm sure you have very similar intake forms where we're going to get a lot of developmental history from that case, because I want to see, like for me, I'm looking for, are there a presence of these hemispheric imbalance types of symptoms? I'm looking for red flags in the history that may give me some states of underlying metabolic aspects, obviously wanting to know as much as I possibly can about the woman's menstrual cycle, and looking at, in relationship to that, is there any symptoms of autoimmune expressions that, maybe she does not realize there is some symptoms that become related to that. So I think it starts with, doing a good case history, first and foremost. And then for there, we obviously have certain questionnaires that are going to be specific to neurological function, that allows me to then start maybe beginning to get a framework of how I may go in and do a specific exam. And, again, do I need to, is it a short exam or is it more extensive? It's going to obviously be based on, some of that history that I find in that case. And then, just walking through that very consistent examination. I mean, going through, again, looking for primitive reflexes, going through, checking their vestibular, checking their balance and their muscle tone, and all that we do as a functional neurologist. And then at that point, if in the case history, I would have seen if there was any labs, if there was any recent labs. If there were no labs, then, I'm already beginning a workup of like, okay, what labs do we need to start, running in that case? And, for me, I'm not going to immediately jump to advance, functional medicine labs and run a complete hormone panel and stuff. I want to start looking for, hey, is there underlying anemia? Is there underlying blood sugar dysregulation? Is there any, thyroid stuff going on? Is there electrolytes? I can just tell you, just at my own experience of working with that age population of 18-year-old girls to 25-year-old girls, I've dealt with a lot of symptoms by just, or a lot of problems just by balancing their blood sugar, okay? And looking at their blood sugar adrenal mechanisms that might have, or, they have pro-inflammatory mechanisms. And we know there's a ton of research on pro-inflammatory states and PCOS and painful menstrual menstruation and stuff. So, I mean, these are things that I think that you got to start going through your differential and working, the hierarchy, rather than just saying, hey, I'm going to jump to these fancy labs over here that look shiny and great for social media, and I'm going to run a stool test and do all this stuff. You may end up there eventually, but check the obvious. Go for, is a person have an underlying anemia? Do they have an underlying anemia that might be being driven by an inflammatory response? Rule out the pathology. Some people may actually have a pathology that you might be the first person to discover that frank pathology. And so that might need, again, extensive labs, or you may have to order, some imaging, because you suspect certain things that may happen. I mean, I've caught, pituitary tumors in people and stuff that, based on their history, you're like, hey, we might want to go get an image of your brain and stuff. So I think doing that, I mean, never immediately jumping to the flashy labs, and never not doing some type of physical exam. And I think that's the other part that's frustrating in the functional medicine space, is that people don't, in the functional medicine space, and I know that Tis Karazian talks about this all the time, that they don't do functional exams.
Correct. Yep. Yeah. There's typically an absence, it's just more of like, okay, we're here talking and everything else. And like you said, it's sad because there's a lot of females who have issues. I mean, like their ferritins don't even get checked. It's just like,
Yep.
and menstrual cycle. It's like, oh, like it should be gory and horrible. It's like, what? Like, and it's like, what happens to your brain when that happens? Like, do you understand how inflammatory that is? And then on the other side, it's the teenagers, it's the young adults who really get the shaft with anything neurological and mental health, because once you mention anxiety, like, oh, well, it's just anxiety, and then everything's really focused around anxiety treatment. But one of the things I see, especially in like, not even just visual processing, but I find when their eyes do not perform their job appropriately, they are very prone to anxiety in crowds, in groups of people, at grocery stores. And I explain it to people, maybe you won't agree, but I tell people we have the concept of anxiety wrong in general. We think anxiety is the brain is processing too fast, so we must slow it down. But for a lot of the people I see who have all these visual issues, it's that their brain cannot keep up with the outside world. And so it's like they're watching a movie at 2-3x speed. And they're just like, look, I just can't do it. I need to leave and retreat. And then next, like, oh, they're anxious or they're super introverted. And when in reality, that's not it.
No, you hit the nail on the head on that, because especially in the learning disability, and I can just tell you my own self experience early on in my own childhood with a pretty profound learning disability. And when I couldn't read and I couldn't spell, the last thing I ever wanted to do was be asked to get up in front of a class and try to spell. Okay. Or, I mean, if I knew we had a potential day where we were going to have like, hey, a spelling quiz, play the spelling, bee kind of thing. And I'd come up with all kinds of excuses not to go to school or whatever and stuff. And so I think that you're right about that. I think that again, this idea that we have to get away from, we have to educate our patients to stop being and just get on, and say, oh, I got all these symptoms, it must be this, because then they have this whole perceived self-diagnosis. They've self-diagnosed themselves, and then they went and found some podcast or something or anything, and now basically confirmation bias themselves into that. And then you have to go, no, that's not the mechanism. Here's the true mechanism, the multi-mechanisms. And I think that's the big thing too, is that, I think as we've learned from some of the greats that we've learned from, again, patients can have a multitude of mechanisms that you're actually trying to trying to go, okay. And I think that's the other big thing that's probably helped me over my years, is to say to a patient that, okay, there's probably about 5 or 6 different things going on with you right now. And we have to try to prioritize the number one thing. And so, for example, like with the ferritin, okay, and the woman walks in and, they got low iron saturation, they got low ferritin level. And we've always been taught that obviously neurons need 3 things: glucose, oxygen, and stimulation. And let's say we got underlying anemia, how good is brain rehab going to be in that case, right? Probably not so great. Probably going to run into some fatigue mechanisms when we try to go rehab that brain. So I think in that instance that you're trying to prioritize the situation. So I think that's for me, my thing now with my patients, and why I do my case reviews the way I do them, and my follow-ups, and say, hey, I want to write up, here's the order that we're going to do things. And that order may mean we may spend, and I think we've all heard our other colleague that's our mentor, Dr. Yannick, talk about this. We may spend 6 weeks, 8 weeks, maybe 3 months or 4 months on step number 1, and hopefully you're okay with that. But I think the world that we have to fight against now is that everybody gets on these social media platforms and, well, I heard this person say this and this. That's not reality, okay? They're just trying to rope you into their program or whatever. They're not working with reality patients. I mean, I see some of the toughest patients, and I know you do as well. And, sometimes we get beat up, right? Sometimes they're like, holy moly, like, what else is going on with this patient? Why are they not responding? What am I missing? Okay. And I think that's okay too, because that's how we learn.
Correct. Yep. Anything else you want to share with the listeners?
I think we covered a lot, man. I think that I think for us, I want patients and listeners to understand, like you said, is that things are emerging and more than ever. And I mean, I think obviously probably the biggest profound impact that's happened in our lives in our practice over the last 5 or 6 years is obviously the role COVID has played in patients' health and really understanding the concept now of what we call immunometabolism, understanding the role of how your energy or your metabolic state, and looking at so many of the people that had abnormal metabolic states like your diabetes, your pre-diabetics, your insulin resistance, all your people that had autoimmune disorders, inflammatory conditions, patients that never took the time to check their vitamin D levels or their vitamin A levels. Those people did not do well if they caught COVID wildly or they got the jab. Okay. And now we're seeing a lot of downstream consequences of that. And so I think that's a big thing that, patients need to, again, start really addressing with their practitioners is, how do I start getting myself more metabolically stable? And am I getting the best metabolic workup? So if you're going to your primary care provider and you're only going to get your basic CBC and your basic metabolic labs, try to ask more, or find a practitioner that's willing to go deeper and do all that for you. And then find somebody that obviously has, tremendous experience in, managing those type of cases.
Correct. Yeah. And whenever we talk about, getting more labs, I know a lot of people will come in and be like, I had a lot of labs done. I'm like, how many vials did you give? And they're like, 3. I was like, okay, $30 worth of labs. I'm
Yep.
like, I'm kind of a 9 to 12 vial guy, depending on what we're doing, because there's just so much more depth that can be had than what most people are getting. But, I hope people got a lot from this. And, so you've got a clinic in Georgia outside of Atlanta, but, if people want to learn more about you, what you do, some of the education that you're teaching, because you do put a lot of information out there, where should they go?
Yeah, I mean, the best way to find me is really just on my Instagram account, Dr. Peter Scire, or my Facebook account. They can find me there. Then we're always posting about, I'm a co-host with Dr. Robin Miller on a podcast called A Little Method Everything Brain. About 1 or 2 podcasts a month. I'm a little behind right now because we haven't been able to catch up with each other because of our busy schedules. And then a lot of times, we're teaching together. Right now, we just did a full year-long program back in 2024 that is now available online, that practitioners can get if they want to learn a more in-depth level of developmental neuroscience and then also the neuroimmunology. I'm blessed that I get to represent Dr. Yannick and share some of his work to practitioners during those courses and stuff, and introduce a whole new age of practitioners to his work. And then I think next year I'm hoping to have some other seminars that people have been wanting me to participate in and teach, and just be able to teach more of this neuroimmunology to them.
Nice. All right. Well, thank you for being here. This was a really good episode.
I appreciate it, man. Thanks a lot.
Yep. If you have found the material valuable, please subscribe to my YouTube channel, Dr. Spencer Zimmerman, and leave us a 5-star review on Apple Podcasts or where you normally listen to podcasts from. If you would like to work with me, visit peakbrainandbody.com to learn more. You can find me on YouTube, Instagram, Facebook, or TikTok, all with the handle Dr. Spencer Zimmerman. I'm also on X with the handle Dr. S. Zimmerman 5. This podcast is for general information purposes only and does not constitute the practice of medicine, nursing, or other healthcare professional services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials are to be used at the user's own risk. The content on this podcast is not meant to be a substitution for medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition that they have and should seek the assistance of their healthcare professionals for any such conditions.